What's going on, everybody? Welcome back to the podcast. It's Dr. Nessim here, and today I am with Heath Villaman, who is a healthcare expert who I was actually connecting with on X as I'm interested in opening my own private practice. And this seems like the guy to know because he helps physician entrepreneurs that are trying to go independent, really build out, whether it's a clinic or even a bigger enterprise, how to go about that. As us as physicians are not always trained in this space, so it's great to have experts like Heath come on. So thank you so much, and I really appreciate your time.
Thanks for having me.
Awesome. So can you, I guess, give a little bit just of your background to how you got to where you are today? I know you said before when we were talking offline that you're like quasi retired, but you do consulting now for independent physicians. How did you get to that point?
Yeah, absolutely. So I've only ever done healthcare. I can't change a tire. I do healthcare pretty good. When I was 15 in a small town in Northwest Louisiana, I started working for a family physician and he had me stocking a drug room. And then at lunch, we would talk about the drugs that I was stocking and how he wanted them in different rows and different classes. And the theory was that I would become a family physician and go back to my small town and take his practice over. And got into college, had a problem with authority, and both of my medical school interviews did not go according to plan. And I was wanting to do psychiatry. So the only other option was to get a PhD in clinical psychology. There's only one school in the state of Louisiana that had it. Couldn't do it. The date that I was supposed to start, because it was past application dates, I got offered a job as a director in a rural hospital. And that's what I have been doing ever since is healthcare administration. Ended up going to a fancy grad school in the Northeast and in New England, and s- had a great time and wonderful professors. Most of my work has been with very, very large health systems and governments. And then in 2018, mainly started working for very large corporations that had a stakeholder interest in healthcare. And then I was sitting in a hotel room, March of 2020, and I got a call from a law firm about an issue with a physician-owned hospital. And I knew about physician-owned hospitals peripherally, but I had no idea how bad it was for physicians. And so I've really been trying to right some wrongs that I contributed to in my consulting world. And I sleep better at night. Money's not great, but I do sleep better at night. Working for physicians and getting them in the right enterprise and trying to restore physician patient relationship. That's really it.
Yeah, that's definitely something from the physician side I could say we need right now. So what do you mean? You said there was an issue with a physician at the hospital. Was that a physician that worked for the enterprise you represented? Can you explain that a little bit more?
What there was an for the reason the law firm that called.
Yeah. Yes,
Yeah.
yes.
So what was happening during this time was CMS was on March 4th, CMS suspended survey and certification, March 4th, 2020. And states started to try to actively close physician owned hospitals, calling all of their surgeries elective in nature. And this was a push by the American Hospital Association. A lot of people got caught up in kind of the mass psychosis that was during COVID. I remember sitting in hotel rooms thinking, how is this working? And by the way, that's an apolitical statement, nonpartisan. People are still getting caught up in that. It was, I have 12 hours of graduate level epidemiology, and I would sit there and think, what in the world? I had infection preventionists in my little consulting firm who would not leave their house, and had been nurses for 40 years. It was a very bizarre time. And there was a group of people that were trying to crush physician owned hospitals at this time. They saw an opportunity to stop, to really kind of dig their heels in, and they were going to use CMS to do it. And so there were state rules that were being pushed in a bunch of different states, and so it's kind of where I really started to see this very large systemic push to extinguish physician-owned hospitals. I did not know how bad it was. In the world I came from, they were just an adjutant. Physician-owned hospitals, a group of orthopedic surgeons, they take a little service line. But in health systems, we depend on Medicaid supplemental payments and Medicare cost distributions, the way that it happens. So, in fact, most rural hospitals in this country could not survive on commercial insurance. Most people don't know that. They survive on Medicaid and supplemental
Yeah,
payments.
that's interesting. So they're getting more, you're making more from Medicaid, essentially reimbursement from the government
A
than if you were
hundred
just
percent.
taking commercial
Most people
insurance.
think that like Blue Cross Blue Shield is the gold standard, or Anthem, whatever, big plan is in your state. And that's what all the hospitals want. Not rural hospitals. Rural hospitals couldn't survive on commercial insurance, on the gold standard commercial insurance, even cost-based programs. They couldn't survive on it because they have been on the tit for so long, they don't know how to do it. And it's a problem in economics. The problem is very, very simple. The problem is dislocation of capital. So, and we see that with large health systems too. Other than HCA, if a large nonprofit health system had greater than 60% commercial insurance, they would implode. They couldn't survive.
Wow. So essentially, these non-profit hospitals are getting subsidized and wouldn't be able to survive. But if you had a physician-owned hospital or like a small physician group, it seems like the reverse. Like their reimbursements from Medicaid, Medicare are lower than that of the commercial insurances, right? So it's almost on the flip side.
That's exactly right. And it's really basic economics. So a physician-owned hospital runs like Aunt B's hardware shop. And it doesn't matter how big it is or how small, but they're typically pretty small organizations. But if I went into a physician-owned hospital today, the lead physician in the group, there's always, physician-owned hospitals get a lot of rub, like if there's 47 equity members, it's kind of 47 kings in one throne. And it can be a little dramatic like that at some time. But usually there's a lead physician, and that physician can tell you how much a sponge costs. They can tell you the brand or the manufacturer of the CT, when it was last there, what the depreciation was on it. Um, Try to ask a hospital CEO at a tertiary care hospital, even the manufacturer of the CT. They would know. They had no clue.
Right.
Less what the cost of a sponge is.
And I'm assuming what you're getting at is the fact that the physician-owned hospital here has to run as efficiently as possible, so they know all the money that's coming in and every single expense. Whereas the subsidies that go to these bigger healthcare conglomerations that can rely on I don't want to call them kickbacks, but the subsidies, it doesn't matter because they don't have to be efficient
That's
and they get
exactly
compensated at a higher rate.
That's exactly right. It's the location of capital. So for a physician, I need to know what my revenue is. So I'm consistently looking at my case mix. I'm looking at my high utilizers, looking at my costs. I'm paying attention to both sides of my balance sheet. For a large health systems, they don't look at what we would call above the line revenue. They look at below the line revenue because that's where they make all their money. So those are things like grants from HRSA that a physician-owned hospital can't participate in, supplemental payments from Medicaid that are based on the utilization that the hospital has, um, TIF districts, these taxing districts that they create out of whole cloth to pass these basically fake taxes that are then matched with the state and the feds to draw down more Medicaid dollars that enhances their reimbursement. They look at and they're focused on that. They're not focused on this
Mm,
particular DRG from that's paying Blue Cross and what are the cost inputs there to reduce my cost and to get greater efficiency. They don't pay attention to that because that's not where the money's coming from.
got it.
Inversely, that's what physicians do pay attention to.
So is there any below the line revenue that comes in for a physician-owned hospital?
Rare. No,
It's rare.
no, it's very rare. Number one, physician-owned hospitals did not understand how to game the system. You don't see TIF taxing districts with physician-owned hospitals. Could they? Yes. But do physicians even know how to work the legislature to do it? They don't. Um, a physician-owned hospital I just opened May the 5th. We were looking at, doing some of these things and showing them how to do it. The physicians were so disinterested in doing it, they couldn't focus on it because it didn't,
Right, it makes
but
sense, yeah.
it wasn't even what they're thinking. They're thinking of, I need Blue Cross, I need to get paid X, and my costs need to be X, and here's my margin. So, most physicians just have been left out of the game so long they don't know how it's played.
Gotcha. Now, you going back a little bit, you said you said you just opened a physician-owned hospital, and before you were saying that during COVID, it sounds like they were using that as it was an opportunity to go after physician-owned hospitals. My understanding was that physician-owned hospitals were no longer allowed after the ACA was passed, which was like in 2008. Correct me if I'm wrong. Um, was it that
Yeah.
long ago?
So
Yeah. And so, like, can you explain how there even were physician hospitals that existed to go after, and then also how did you just open one?
Sure. There's about 263 physician owned hospitals in the United States right now today, out of 6,090 ish hospitals. And of that 6,000 ish hospitals, about 4,100 of those are certified by Medicare and Medicaid. So you can open a hospital that is licensed by the state agency. We typically call those departments of health from state to state, and accredited by an accrediting organization. That could be the Joint Commission. For hospitals, that could be the CIQH, that could be the AOA, um, DNVGL. But you don't have to be certified. And what Section 6001 said is a physician may not own a hospital that participates in Medicare and Medicaid, but you can
Got
absolutely
it.
open a hospital that just does not participate in Medicare and Medicaid. And it depends on your market. It would be hard for, let's just say I was opening, these don't exist, but let's just say I was opening an eye hospital that was exclusively ophthalmology. They're so dependent on Medicare that would be virtually impossible to do. This hospital that was just open was a breast cancer hospital. And the numbers on it were just wild. 74% of its utilization came from one payer in the state, and that was Blue Cross Blue Shield. So the
Got
numbers
it.
just really, really worked on that. Um, I've got one in progress in Spokane, in northern Idaho, uh, and then one in uh, northern Missouri. Another thing you can do, for example, the one in Missouri, you identify a license that's available, and maybe the hospital is going out of business. It doesn't have to be a physician-owned hospital. Remember, in every state of the union, in LTAC, a long-term acute care hospital, they are licensed as an acute care hospital. That is what an LTAC is. They go out of business pretty regularly. So, because they're generally run by grifters and,
Yeah, I'm a physiatrist by
oh,
training,
there you
so
go.
I'm very familiar with
Very familiar
the
with LTAC.
long-term care.
Lot
Yeah.
of waste, fraud, and abuse in that service line. So they implode relatively frequently. So you can, if it's physician owned, you can go grab that license and then turn it into whatever you want, general acute care. So doing that in northern Missouri. So there's all kinds of ways to do it. Well, my big
Got
thing
it.
has just been trying to educate physicians. There's a way, there that it's possible.
So I guess when I see healthcare economists and just general discussion on X and things like that, and when they say that the ACA made it impossible for physicians to own hospitals, the caveat should be physicians to own hospitals that accept Medicare and Medicaid, which basically makes it extremely difficult, except for in specific circumstances. Like I'm imagining the circumstances with um, the breast care hospital, it is a group of maybe surgeons that always have to admit their patients after surgery. And they're like, why would we go and admit them at this other hospital where we can create our own? Is that kind of like the idea in that scenario?
It is. It's also just the demographics. So the demographics of breast cancer skew younger. They don't skew towards Medicare age. So whenever you're looking at the distribution of care, what makes sense? So, typically I might get a call from a group of orthopedic surgeons. Orthopedics, depending on the group, can skew high Medicare. But the distribution, if I looked at orthopedic care across the country, is not necessarily always skewing Medicare. But if you do a lot of total joints and that's the bulk of your business, then a hospital today, you really need Medicare to survive.
Right. Makes sense. Okay. So, I mean, it sounds like still, in my opinion, it would be very hard given the current legislation to open a hospital.
Yes.
But it doesn't sound like as difficult to open a private practice, which I think is where, at the very least, the most independence can be gained and
Yes.
needed. Um, but it is still harder than it used to be, and so you need to have to be essentially a physician entrepreneur and want to run a business as well as seeing patients, which I think is why a lot of physicians are just like, I'll take the salary from the big health organization or the PE backed organization and just call it a day. I know myself, I'm looking to start a practice. I think I see a slight the pendulum swinging back a little bit. Where do you see the current landscape for that is? And then also, like, what would you recommend to any physicians who are starting out thinking about just trying to start their own practice?
Number one, if you want to start your own practice, jump into it right now today. There is no better time for physicians to start their own practice right now today. And it seems daunting because you've been lied to for so long. A bunch of goobers that run health systems. These are not smart individuals. They don't even have a fraction of your education. And they don't come from any other industry. They circulate through 6,000 hospitals. That's really all that there is. And they've made it seem like it's some kind of mystical thing. Yes, healthcare is a little bit different. You have to learn some of the acronyms and some of the terms and how reimbursement flows, but you can absolutely do it. You will make better margin than a health system all day long, and your patients will like it more. The consumer can no longer afford the taxes and health insurance coming out of their check. We're in what's called what in systems theory, kind of partly how I was trained with some organizational behavior. In system theory, we are at a point called a mixed transition, and it's where a bunch of different systems are changing very, very rapidly. And we are on the cusp of a major economic implosion. This isn't to be a doomer. It's just cycles. These are natural cycles. These are natural business cycles. We're at the apex of one right now. You're seeing all the mania in the market. It's what, 7 companies control 90% of the Dow today. Um, I mean, it's some kind of insane number. Major concentration. I think the Buffett indicator is like 230%, the highest it's ever been. So we're in a bubble of bubbles. We're in a 1929-esque bubble. And the consumers are tired of it. They're tired of paying $1.50 for a peach at Walmart. And they're looking at their check and they're saying, why am I spending $25,000 a year on healthcare and I can't get healthcare? Why, as a country, are we all fatter, sicker, dumber, and poorer? It doesn't make sense. And people are starting to sit back and say, what's going on? And depending on what kind of cycle theory you kind of lean on, let's just say Strauss Howe, which is popular right now, the generations theory, this would be a fourth turning. And it means that system structures and processes that exist today will implode and new systems will be born from that. So we're at the apex of a fourth turning, and all you have to look at is the consumer. So when people ask me that question, well, how sure are you that things are about to change? And over the next 60 months, and you're going to see radical change in the next 24 to 36 months, radical change. The consumer is demanding something different. And so healthcare as you know it today will look very, very different in 60 months. And it's going to take physician leadership to get out there and help make that change. Um, and it seems scary, but it's really not. And you will be rewarded by the consumer.
So what do you think that different is? Because like right now, it still feels like, some people, if they have the means, right, they can go and do concierge medicine and pay cash for it. But a lot of people are just like, oh, well, I have insurance. This is what's in network. I'm just going to go to this physician. So how do you see that playing out?
I think right now it's going to be a hybrid model, and it's going to be hybrid in a couple of different ways. So, um, you know, if physicians are going to continue to have to take insurance, but nudge patients toward a what we would call concierge model. Really, it's just a cash based service model where I'm going to offer you a service array like a Disney Speed Pass or greater access to me, the physician, and you're going to pay a flat amount. So here in New Orleans, for example, I pay my physician $2,500 a year, and that gives me access to, and I'm talking primary care, and that gives me just the cell phone and care 24/7, 365 in whatever state I'm in, and unlimited telehealth, and one exam with certain labs and metrics every year. Um, but you can devise it however your patients need. I know an orthopedic surgeon right now today who charges $5,000 a year and is doing somewhere around net $2 million on his patients. They get placement. They get to skip the line, the surgical line. They get access to him 24/7, 365, all these kinds of things. So you have to have a hybrid model where you start with traditional insurance, a traditional reimbursement, and then you start to offer the consumer cash based alternatives to that. There are also alternatives to insurance today, like crowd health. I no financial, you know, interest in that entity, or I'm trying to think of the other one that I saw that was really cool on X. Starts with an M. It's not coming to me right now, but Molly Health. Um, uh, but these sharing companies, you will always have to have risk pool of, for at least the next, 10 years in the United States. So you can risk pool major hospitalizations, large chronic disease like hepatitis C or HIV, or, things that consume a lot of resources, but things that are consumption light should be cash based. And what happens with the consumers, we find that it's cheaper. Uh, and then, and then everything's going to localize. So that's the next thing. That's part of this. What you're seeing in this mixed transition is things are going to become hyper local. Physicians are going to do really well to go to the top 5, top 10 employers and say, here's the service array that I can provide for you, that the self-insured employer, and I can reduce your cost by 10% overnight. You don't reduce the cost 10% year over year over year. That's bad business. Could, I mean, you could save them tremendous. You could save them, 60% right now today, but that's not what you would offer the business. You would offer the business an immediate 10% savings, and then they would allot you a certain number of lives, and they can either pay you episodically or like a payer per member per month, whatever's cheaper for the business. So as things hyper localize, that's going to be another way to do this. So there's kind of that 3 tranche approach that I take when I'm either starting a practice or an ASC or a hospital or something like that.
So, okay, so to kind of put an example to what you just laid out, for example, I'll be going into pain management, sports medicine. So for me, I'm going to start a practice. I've gone back and forth. Do I take insurance or should I just go full cash? Now, I have no patient base right now, right? So I'd have to build that up. So you're saying is maybe I get on maybe on in network or maybe out of network. You'll tell me then, so that way it's easier to still get patients in. But I have cash options, also certain things like PRP and BMAC, these types of injections. If patients want to explore it, those are going to be cash regardless because insurance isn't covering. So there are cash options. Maybe there's a membership option as well that gives you a different type of access. And you kind of have that as your starting setup. Then you could also go to big employers I'm in New York. So in New York and say, hey, these are my cash prices. that for all of these services, even if it's things that would be covered by insurance, but those are self-insured companies anyway, and say, I'll give you 10% savings on all of that. And so now I'm getting patients through there. Is that sort of what you're saying? Am I breaking it down?
That's exactly right. So, and remember, when we say big employers, we just mean employers with about 300 employees or more. Not always, but typically, if you've got 300 or more employees, it's cheaper to self insure than to buy commercial insurance on the market today. 78% of an insurer's business, like Blue Cross Blue Shield of Louisiana, is third party administrator. They're administering the self insured benefit of a company. Their biggest,
Can you explain that?
yeah. So most people don't know this, but the largest segment of business for health insurance, and it depends on the carrier. Or I'm just going to take a normal insurance company like a Blue Cross. Their largest segment of business, over 60%, is managing as a TPA, a third-party administrator for a self-insured business, a school board, a sheriff's department, um, a company of some kind. That company is self-insured. At whenever they get a claim, they write a check from it. They just have a insurance company manage that for them, and then that insurance company.
Okay.
But the insurance company's incentive is higher costs because they make a percentage of the company's spend.
So then why does that company use the insurance company? Because if
because
they manage it themselves, aren't their savings going to be much bigger?
because they don't know any better.
They just can't. Okay.
It's done by brokers, and a broker is how are brokers paid? Brokers are paid on a percentage of the spend, a percentage of the spend of the total package. So a broker's not going to say go to Dr. Nessim, who's going to save you money. He'd be losing money. So you have to go. These companies, you would be shocked. When I first started my consulting practice, I had just turned 27. I may have been 26 at the time. The largest animal protein producer in the world that has 50 locations in the US had a particular problem in a town called Cactus, Texas. So I went to meet with them. They're headquartered out of Brazil. Private jets, their US headquarters is in Denver. So private jets from Denver and Brazil and then Houston, Texas, all showed up, and we met in Cactus in this little town. And what was happening is at the time, their healthcare expense was almost $15 million a year because they were busing migrants from Amarillo, Texas, to the plant in Cactus and then back to Amarillo. The bus would literally stop at a Texas Tech emergency department. And if the migrant who worked at the plant who had an ear infection, was an emergency, but they didn't get healthcare any other way. The company itself was costing it just these enormous healthcare dollars. So my proposition was very easy. This is back when I talked about telehealth. When I first started talking about telehealth, people looked at me like I had four heads. And then COVID happened, and suddenly everybody's, oh, why did you do telehealth? So I suggested, a quasi telehealth and on-site healthcare program. Guess who crushed me like a little bug? It wasn't the corporation who wanted to save it. The corporation wanted to do it. It was Blue Cross Blue Shield of Texas. Why? Because it cut into their dollars.
Mm-hmm.
And I learned a very valuable, and I'm talking about crush me. It was, I still wake up in the middle of the night thinking, God, it was embarrassing how bad that I got crushed by Blue Cross Blue Shield of Texas. And they were the
What
third
do you mean by,
trader.
like, they were just trying to make it any way possible that you couldn't have this employer set up a primary care doctor
They
on
made me,
site for?
oh yeah, they made me seem like an idiot. This 26-year-old, 27-year-old doesn't know what he's talking about. He's not been in healthcare this long. This is dumb. No one does this. Well, guess what? In industries today, do you see on-site healthcare quite a bit? You do.
Yeah, I was just talking with a friend of mine who works for Pepsi, and they have in their building one of the concierge medicine like practices that just treats their entire company.
Absolutely. Absolutely. And now it's very, very commonplace. It's very, very commonplace because healthcare was just getting so out of control. And what was happening is these companies were going from Blue Cross to Cigna to Aetna to different, you know, Gills Bar to different uh, TPAs. And so to retain them, they started driving down their costs maybe 3% a year, 5% a year. So but and then they catch them on other administrative expenses. So they were still making money, but they just caught them in different ways. Now
Right,
it's very,
right.
very commonplace. But what you should do is like a physiatrist is say, okay, well, I'm going to have this service array. So are you going to have a gym? Are you gonna and can community members go to that gym? Do they have to be patients? Are you gonna have a physical therapist?
Yeah, that's the plan.
You know,
I
so
was gonna do it seemed like PT is difficult to do insurance based, so I was just gonna do cash PT. Um,
so you
but
bundle
yeah,
it.
that's the yeah,
You
exactly.
bundle it all together. Maybe you're doing acupuncture. Maybe you're doing you know, other kinds of alternate uh, methodologies that supplement
Mhm,
what you're doing in an allopathic way. Because that's
mhm,
what the consumer wants, by the way. We're seeing this cycle is just like the 1980s. We're hearing a lot about yoga. We're hearing a lot about yogis. We're hearing a lot of new age talk. You're having another satanic panic. This cycle and every cycle that you have, every time there's a cycle occur, it amplifies. I'm not afraid of those things. I lean into them. So that's because that's where the consumer's at today. So you want to offer packages that are wellness forward, wholeness forward, and it supplements your allopathic service line. That's where you want to be.
right.
And that's what you would
Interesting,
take
yeah,
to an employer. You know, you'd say, look, we do all of these
right.
things, and you can get it a flat fee per employee per month. And the goal for you is I'm going to return that employee back to your productivity. That's what they need. They don't want the employee out missing work.
Yeah. So are you saying now these employers they're getting smarter where they're not using that insurance company to do the administration for them?
Well, they still are as bulk, but what they do today is if a physician will call them up and say, "Hey, here's what I'm doing. You can have a meeting in a week." There because healthcare costs right under salaries and wages is the largest cost in a corporation. So if you can help
Mhm.
drive that down, corporations, they are an entity, they're an organism, they're living. It's not about the CEO, it's about a return to my shareholders. They've got to return value somehow. If it's a school board, I've got to return it to the taxpayers. What am I doing with the dollars? And consumers and taxpayers today hawk-eyed about money. So if you can go down and you can drive their healthcare costs down at all, 1%, 2%, that's a big deal to these corporations.
Now, do you feel like these trends that you're talking about in this transitioning period is going to require legislation? Because before you said something about how like the margins on my private practice could potentially be bigger than a health system, but really, the isn't it true that the a health system outpatient uh, office can bill at a much higher rate than I can, um, if I were to be, like, fully independent. So, technically, their gross revenue is gonna be higher, and potentially their margins then might be higher in a sense because I just can't bill at that same level even though I'm providing the exact same service.
That's a great question, and you're exactly right. So you would think their margins would be high, but actually, they're not a nonprofit hospital has no shareholders to return. So what do we typically see their margin? Sometimes
Yeah,
it's
they're very
negative.
small. Yeah, yeah, yeah.
Sometimes it's negative. One of the reasons is because you got the goober CEO flying around on a private jet, having board meetings in Aspen. They spend money like a coke addict in the 80s. I mean, it's insane how these hospitals spend money. They're constantly building. They build these little empires, real estate everywhere. So their margin is actually very, very low. But you're not going to do that. A physician doesn't do
Right,
that. A physician, your profit margin could be 30%. And I tell physicians that all the time. If your profit margin is not at 30%, we have a problem. Call me,
right, yeah, for
fix that.
sure.
So your profit margin should all day long be 30%, which is unheard of in business, unless I guess you're Nvidia and We won't get into the circular revenue that NVIDIA has, but that's your margins will be very, very healthy. You just won't have the large amounts of revenue that come into the health system, but your margin will be great.
So, what would you say? At 30% sounds like the appropriate number. Like, I have another business right now, and like when I study business, that seems to be like a number that's
The
very
basic.
healthy.
Yeah.
You're putting, there's always expenses, marketing, advertising, sales, etc. Then you're reinvesting back into the growth, and then the rest hopefully would be take home for the physician and the partners. What when you're advising independent practices or physicians that are trying to start, what are some of the things that you recommend to them to get to those margins? Like, where are some of the or big mistakes you see physicians making that you're like, oh, you have to call me. You're running at 15% margins.
Yeah, the first thing is whenever you're starting the enterprise, physicians are afraid of debt, typically because they've got so much debt. You should never be afraid of institutional debt. So if physicians, a lot of physicians are Dave Ramseyite people, and I am not a Dave Ramsey type person. So you use institutional debt to support your ongoing business. You understand the difference between short-term debt and long-term debt, and you get the main problem you see with physician enterprises is they're just not well capitalized, and so that can lead to cash bubbles and very, very tight buttholes. We don't like that. So we want you to be relaxed, be well capitalized from the get go, and also you have to make sure that every member of the enterprise has value. And it doesn't always mean that it has to be cash value. Those physician members may provide productivity as an investment for a period of time, that equates to value for the enterprise itself. It doesn't mean that every shareholder has to bring $100,000 to the table. It means that you all appropriately use institutional debt and your most valuable resource, which is your productivity, to pull in the same direction. And then do things that health systems do. To one of the things that physicians are really, really bad at is they have Willy Wonka level paranoia, and they're very afraid of working in groups. They see it as very competitive, and it's how you're trained. But there are 400 million people in the United States today that we know of. 400 million people.
Right.
There are only 1.1 million physicians. 58% of that 1.1 million is primary care. There's more than enough market. There's so much
Right.
market.
Right. Yeah.
You can tap it if you wanted to tap it. You can make as much as you want to work. All there isn't a so if you will
So,
collapse,
what do you mean? Yeah, you're gonna say. What do you
yeah.
mean
So
by
it's,
working in groups?
if you will collaborate, that doesn't mean you share the same NPI number. It doesn't mean you share the same EIN. But for example, maybe you create a clinically integrated network, which is kind of the new IPA, or these integrated delivery networks, that IDNs that are kind of new and novel. And the incentive from the federal government is to kind of get around Stark and Eddie kickback by proving value. So I'm gonna put you need to talk to a healthcare lawyer, specifically healthcare lawyers who work on this. McGuire Woods, a great law firm for physicians. Nelson Mullins, probably the law firm that does clinically integrated networks and IDNs. But even if you never negotiating contracts through that CIN, you could negotiate your cost through a GPO. The more people buying from one enterprise, you scale your costs.
So, you're
Again,
saying like negotiating supplies, negotiating insurance contracts? Is that what you're talking about? Like
that's
pooling the
exactly right.
resources
So on the
together?
revenue side, the more physicians that you have in a CIN, you can negotiate better contracts. On the expense side, the more physicians you have in a CIN, you can negotiate your costs. But you can also
And
do
what
cool things like lease employees back, which is there's some tax benefits, and so there are all kinds of cool things. Think like a system thinks, and you can do it on a small scale.
and what does that have? How does that have anything to do with anti-Stark laws? and kickbacks?
Yeah,
Because you're saying
because
like, because right now I can't give money to a physical therapist for referring me a patient, but if I hired that physical therapist into my system, I could
that's exactly
essentially,
right.
which
And
is silly in my
it's
opinion, but
stupid.
that's like the way the law is written. So how are you getting around that?
So there are some law. Well, an IDN
With the
allows you.
disclaimer that this is not legal advice.
This is not legal advice, and you need to talk to like sophisticated people at McGuire Woods or Nelson Mullins or firms like that. But the idea is that if you X, Y, and Z physician today wanted to share your commercial contract with each other and say, here's what I'm getting paid, here's what you're getting paid, you cannot do that. That is prohibited. They could terminate your contract and probably liquidate you in certain circumstances. You need to be very careful about that. But a clinically integrated network provides you the ability to negotiate with payers as a group of physicians, not under the same NPI, not under the same EIN. It allows you negotiating power. I'm not a fan of ACOs. They
What's
typically
that?
that's an accountable care organization. These came out probably 2010, maybe a little bit before 2010. Mayo couldn't make it work. Johns Hopkins couldn't make it work. We kind of have a new iteration of ACOs today that are doing a little bit better. But the theory at the time was hospitals would come together, they would negotiate contracts, they would have distinct service array, and they were going to kind of be subcapitated to payers, and but they all failed. Um,
Mhm.
sins are completely different. It allows you the flexibility to do what ACOs were always supposed to do and not have to show each other your underwear drawer. So in a sin, I don't need to see your income statement. I don't need to see your balance sheet. We're not going to have a biller and everybody's going to see each other's billing. It helps control that physician paranoia. Um, Now, over time, when you really want to scale, that's another business that physicians could throw off. You could throw off a MSO, a management services organization. You could throw off a billing company. You could throw off your own um, resource group that is a GPO. Eventually, you want to have a corporate constellation that has all of these aligned companies that provide different revenue for you, and then whenever you are ready to liquidate your enterprise, you want to sell it to a health system, you want to sell it to a payer, you want to sell it to private equity. However you want to do that, you could sell off bits and pieces of your companies. That's what I try to create. I take one physician or a small group of physicians, and I treat them just like I would treat private equity today. Just I would give them the same advice I used to give private equity, just the same advice I would give health systems. We just started at a smaller scale.
Got it. And the MSO is interesting because that's so for those listening, and correct me if I'm wrong. So that's a managed service organization. It allows essentially, at least when I, from my initial understanding was like private equity you can't technically own a physician practice don't if you don't are not a licensed physician. So, but you can own the MSO, which does all the like business back end for the private practice. And then the private practice is contracted with the MSO, pays them a certain amount of money every month, which is probably like most of the money that's actually made, because then they own the MSO. The way I was thinking about an MSO, like for a small physician practice, and I'm curious why you recommend it, would be like if I wanted to raise money from friends and family, well, they can't, if they're not a doctor, they can't invest directly into my practice, but they can invest into the MSO. Does that make sense? Are there other like reasons you recommend it specifically?
Well, so what you're talking about is to get around the corporate practice of medicine. And I think I don't remember how many states there are. I don't remember, it's like 38 states that have corporate practice of medicine laws. Louisiana is not one of those states. Texas is. Ohio is a corporate practice of medicine state.
Yeah. I think New York is where I
New
am.
York
So
is, absolutely. So you have to have that MSO to do exactly what you're talking about. But an MSO can also be functional in nature, and it can be an investment vehicle, just like you're talking about. It can also be if I have a group of physicians and I am the lead investors. And I'm designing the corporate constellation, and I'm going to be there doing the work every day. And I want to manage the practice. It's another way for me to take the expense prior to the distribution. And MSO is an expense. So
Right, right.
if I'm private equity,
Because it's an expense to the private practice company.
that's
Because the private
exact,
practice, the revenue that comes into the private practice company then pays out to the MSO.
that's exactly right. So, and I'm going to take Louisiana nursing homes. They've done this the best. Louisiana is a healthcare state. We learned the game very early on. We had a governor who was very plugged into it. But let's take a Louisiana nursing home. I have the nursing home, and I may have community member investors in it. But I have a management company that sits on top, and so I want to make money and I want to get distribution. So what I do is I'm the one managing the nursing home, and I manage out what we would call manage out the distribution. My cost is so high here. Maybe I'm charging $1 million a year. Maybe I'm charging 2 million, $3 million a year just in management fees that come to me. That's an expense before EBITDA, before a distributable number. Does that
The
make sense?
it's an expense to the nursing home.
It's an expense to the
That's
nursing
yeah.
home, but
Mhm.
if you think about it in maybe a negative way, it's an expense to your other shareholders. So
Mhm.
because
Mhm.
that's an expense that's going to take away from their dividend. But
Correct.
it's a
Right.
crafty way, what we would call, just getting skimming cream. It's a crafty way to skim cream. But MSOs can also be very, very beneficial. They can help you scale, and they can help you reduce your costs, drive your costs down, and drive your revenue up. So, and it's karma. Bad if you have bad intent, there are vehicles for bad intent, but it can also be a vehicle for good intent as well. Um,
So do you recommend to any practice starting out, even if it's just a small one physician, two physician practice, have an MSO available to them, or it's
yes,
not always necessary?
yeah,
Okay. So what
it's not always necessary, but if you've got a group of physicians that are usually, and I say four or more, if you have a group of physicians that are four or more, and there's one physician that's really doing the work of managing it, that physician should be compensated for management. And the proper vehicle for that is an MSO, or what we all used to call a management company. And that
mhm.
physician should be compensated based on their production and how they manage the organization. That's the appropriate vehicle for an MSO. And I usually say, four or more physicians. There should be a management company or an MSO.
Got it. Because you're not, but why not just have that physician that's doing the management have like higher equity in the company?
They could. They could do both. I like to set it up as both. So if you're the founder, quote unquote founder, if you're the founder and you're the one who's going to drive, you're the captain of the ship, you should be compensated equitably for that. You should have more equity. You should get a management fee. And again, the MSO allows you to get around Stark. So I don't have these capitated arrangements because MGMA says how much a medical director can get paid, all of these kinds of things. So this allows you to kind of get around some of those things.
Really,
Again,
in your own private practice, the salary could be determined.
well,
You're saying,
rem-
like
remember,
if I start a practice and I employ four physicians, and I don't have the MSO,
are they
you're
going to be
saying
bona
that
fide W-2 employees?
they would probably be, yeah, let's say W-2, and then they want like a partner track.
As long as they're bona fide W-2 employees. Again, I don't like to get into the legal help. You need a
Mhm.
sophisticated healthcare attorney. I can help you with that, but I always point people McGuire Woods, Nelson Mullins. I use Norton Rose Fulbright a lot out of New York, as a great healthcare arm. Hall Render in Texas, very good. Um, but it just depends on how you set those arrangements up, and but a sophisticated healthcare attorney can certainly help you with that.
Got it. What other key employees do you think is important for someone just starting out, right? Because there's definitely a balance where you're saying you seem to be under the let's take on wise debt and really get it off like the practice up and running. Let's not just try to, you know, be a one physician, or maybe you do, but where you're just starting out by yourself and then scaling up. But maybe like, I may want to start with, I'm going to have a front desk person. I'm going to have maybe a medical assistant, right? That salary is not going to come from anywhere unless I take out a loan.
That's
Are
exactly.
there any other key employees you feel are necessary if you want to have like a legit practice that has like the ability to scale? Like, could that even be someone in business operations? Like, my brother's in healthcare consulting, and like we've always said it, down the line, like I'm still going to see patients. Like, I am a doctor first, and I know you understand the business of medicine. We're going to come together. He would technically have to only own part the MSO because he's not a doctor, and like have someone who's like working on those business operations and on a day to day. What do you see as like some of the key components that you see for successful practices?
Well, after doing this a long time, I can tell you. Let's just take a physician practice. A physician practice, usually you need, for one FTE physician, you need about 3.5 administrative support staff, and
Wow.
we're going to include one clinical person in that. That's a hybrid. So that is a person who's like a nurse or a medical assistant who also does some administrative tasks.
1 to
So
3.5, you said?
yeah, usually it's 1 to 3.5.
Interesting.
And, and then of course, as you add on, one FTE physician, you're adding on typically 1.5 FTE staff. So that
So the first physician needs 3.5. The next physician, you add on another 1.5. Is that what
That's
you're saying?
correct. That's exactly
Got
right.
it.
And what you start seeing is it leans clinically heavy. Um, and there is a science to staffing. Typically, unfortunately, physicians will overstaff because the nature of a physician is they're helpers. And so when their staff comes to them and say, I can't do anymore. I can't do it. I need more staff. Physicians are
Right.
like, okay, to solve this problem, we're going to throw money at it. We're going to add another staff member. The problem is overstaffing is just as bad as understaffing. It creates inefficiencies. It's from the science of social loafing and the diffusion of responsibility. So you want exactly the right amount of staff, and you want to be lean. You should leave. Every staff member should leave. They should be tired. They should not be exhausted, but they should be tired. And there's cognitive battery tests, psychometric tests that are validated long over time that we can even give in organizations and test that. But it's to a point now where I can walk in and I can tell whether you're overstaffed or understaffed. It's a
It's
feeling.
interesting.
It's electricity in the air. You can tell.
I feel like that's not something that's talked about often at all. It's like no physician ever. I've never heard 1 to 3.5. That's such an like interesting number that makes a lot of sense.
I'll tell you, for physicians that MGMA is a great resource. They have tons of data sets.
What's that? MGMA.
MGMA, uh, Medical Group Management Association.
Okay.
I had a professor in grad school who wrote some of the governance books. And we all had to be members of ACHE, the American College of Healthcare Executives, MGMA, and they wanted you to be fellows in both. But MGMA has fantastic data sets. It is the source for physician pay. So if you're a third party evaluator who is working for a hospital or a health system or private equity who's going to tell you how to pay a physician, they're going to use MGMA data. They may supplement that with something like Merritt Hawkins or some other data sets. But the main data set we use in the United States for physician pay comes from MGMA. But they have other data that's just fantastic, revenue per square foot. I mean, just fantastic data sets.
Wow. And can anyone just sign up to get that data? Like, can I get that
Absolutely.
data?
Yeah, I mean, you pay a healthy price. It's very
Hmm.
expensive, and all these surveys are done
Or we
annually.
could hire consultants like you to get that data.
You can hire consultants like me to get the data, and what I do is I take all of the practices that I work with, and I submit that data every year. And each data set has a different time, but over the years, I've probably been doing that now 15 years or so. I really rely on MGM data. It's fantastic. It's fantastic data.
Now what so that it sounds like that data you said, like, goes to private equity and things like that, so, or what to pay a physician, right? So, like, let's just you say an orthopedic surgeon at a hospital is making $500,000 as their
About yeah.
salary. Um, what is does that data also show what the or maybe this different that maybe it's not in that data set, like, what's the delta on if you owned your own practice versus are working as a salary employee? What do you typically
Yes.
see as the delta of a well-run practice?
Yes, absolutely. It does show you that. It shows you by region, and it shows it by decile. And um, so if you're a physician, and we look at salary very differently. If you're going to pay your accountant's going to want to pay you a flat salary. If you own your
The whole
practice,
amount, the distribution plus the salary is what I mean, yeah,
exactly
really,
right.
but yeah.
But it could be all day long 3x. It could be all day long 4x. And then if you're ever able actually to capture your productivity, let's say you're an orthopedic surgeon, I want to capture my productivity in an ambulatory surgery center or at a hospital. Now we're talking 10, 12, 15x your
What does
salary.
that mean by, like, you, capture the productivity, meaning you own the ACS as well?
Yeah, you have
Or
you because there are two components to care. There's the professional component, or what we would call the Part
mhm,
B component. And then there's the Part A component that is the technical component. So when I go to a hospital for a total hip, and that's going to be an ambulatory procedure most likely for me, I'm going to pay the physician a fee, and I'm going to pay the hospital a fee.
right.
So if you own the hospital, which you should, or at least if you're an equity member, you should participate in your own production. That's what I keep saying to physicians. Why give away your productions to hospitals and health systems? They do
Yeah.
nothing of value. They produce nothing about. They're like when I first started out, I used to think lawyers were the dregs of society. I really did. And then um, I became a consultant, and I was like, oh my god, we're just a bunch of assholes. We're the most terrible people on the face of the earth. And then I had to hire a lobbyists. And I've had lobbyists on staff now for almost 20 years. And I'm thinking, God, these are soul stealing, terrible human beings. Um, and then I met investment bankers, the absolute dregs of society. And it really gave me a higher view of myself in that world. But the point of that whole thing there is physicians should not be giving their productivity away to people who produce nothing of value. At least a lobbyist produces a bill that can subsidize some of your income, or the way I like to look at it is return my tax dollars. That is the way we look at that. An investment banker, I still don't know what an investment banker does. I don't know what they produce, and it's kind of like a hospital CEO. And I say that as a former hospital administrator. We produce nothing of value. We have a structure where the physician, who is the producer, comes in and we take half of your production. And then we pay you some little sprinkling to keep you producing. It's
Mhm.
it is the matrix. You're living in the matrix. All you do is just cycle around and around and around. Why is physician schooling so high? The LCME works directly with the American Hospital Association. We need you to come out in major debt so you don't
Right,
go into
otherwise
this on your own. We want you to be so afraid that you cannot live. A physician wants something very clear. Physicians all have the same thing. They want 2.5 kids, a white picket fence, one dog, and a little subdivision somewhere, and at least one Mercedes, and usually like a Yukon or some kind of SUV that the mom can go do that. That is what a physician has. So as a hospital administrator, we want to fulfill that dream, but we want you to never catch up. We want you to
right.
always be on the wheel. We want you to die in an OR or die in the clinic and then let your life insurance pay off, or maybe we've got a key man policy on you or something like that, and we get to share in even your life insurance. That's what a hospital administrator wants.
Right. Wow. Um, so to that point, um, to buck the trend and to get back to more independent physicians that are living the dream, is there any, to kind of like conclude this discussion, because I feel like it's been really, really insightful and I appreciate it. Is there any legislation you feel like, because I asked this before, I don't know if we ever got back to it, that you'd like to see that will help in that process, that really can make a big difference right now? Because I know right now, as we're recording this, healthcare premiums is a very hot topic. The government is currently shut down, and that's basically what's being the point of contention of why it is. It doesn't honestly seem like either the Democrats or Republicans really understand the healthcare economics of what makes sense and what lowers costs. So what do you see can help that? And then what would you like to see which will make your job easier and physicians' lives easier when they're trying to go out independently?
Yeah, absolutely. So I typically discourage people from trying to achieve legislative instruments. It's very hard, and that's for me doing it for a very, very long time. For the first 5 years of my career, 4 months out of the year, I was parked in Baton Rouge, walking back and forth from the Hilton of Baton Rouge to the legislature. Um, and even then, in a small state like Louisiana, it's very, very hard to get the bill you want passed, and to effectuate the change you want in the legislative process. It's meant to be slow and deliberative, so that's not where you can get great change. However, in a regulatory body, with a stroke of a pen, I can interpret the legislation. So, for example, right now, today, HHS, which I have proposed to them, is to declare a public health emergency, just like we did during COVID. Just like we did during COVID, we suspended the bulk of Stark and anti kickback because the secretary can decide what needs to be suspended during a public health emergency. That public health emergency can last, like COVID did, almost 5 years. It could last however long we need it to last. During that time frame, we can move major pieces of legislation. But right now, today, what we need is to suspend the bulk of Stark and any kickback to allow physicians greater negotiating power, and to start their own enterprises. We need to that that Stark and any kickback would also trigger the physician-owned hospital moratorium, and some investments in multiple vehicles like IDTFs, ASCs, things like that. We need to incentivize. There's some just
What
structural
about site neutral payments?
site neutral payments. We can strike those. Again, that is a regulatory decision. We don't need legislation for that. Provider taxes. That's a scheme that physicians can't even participate in. They really don't know about it to participate in the scheme. Um, but we could eliminate all those through a stroke of the pen at HHS if we could declare a public health emergency. And while we're doing that, then we could have a large wraparound bill that we could push through Congress. Uh, Big lobbies don't have as much influence with regulators. They do have influence with regulators, but they don't pay regulators like they pay congressmen. So it's easier to make change with the power of a pen with a regulator. And right now, physicians do have, rightly or wrongly, and this is apolitical, nonpartisan, but physicians have friends at HHS in Bobby Kennedy and Dr. Oz, who was a Pennsylvania physician, and Jim O'Neill, who's the deputy secretary of HHS. They are
Mhm.
physician friendly. They are own. They have their own list of priorities, and we're low on
Right. That's what I like. Some of the things they're saying, I feel like they're not doing. That's why
Fruit
I
Loops
think
is
I'm
a very
asking the
big deal
question.
to these guys, and
Yeah. Like I'm not concerned about that, to be quite
right,
honest.
and raw milk and things like that, and I understand it from, like, I understand the macro themes of this. I totally get it, but we need some real world change very, very quickly that's practical in nature. And that's everything from, just like you said, site neutral payments to Stark and any kickback repeals that we can do with a stroke of a pen if we were to declare a public health emergency. And I'll just tell you, I think that HHS I think it's very possible within the next year you see a public health emergency declared, and it could be an access to care emergency. It could be a physician recruitment and retention emergency. Again, we only have 1.1 million physicians for 400
There's
million
definitely a
people.
shortage.
There's a shortage. It's beyond. So, that's what I'm pushing for. That's the easiest way to get what you want accomplished, is taking some regulatory action. And then while that's happening, push major legislation.
Very interesting. Awesome. Well, this was super insightful, Heath. I really appreciate all
Thanks
your
for having me.
insights. It's been really, really great. I hope we could do it again sometime because there's
Yes.
probably like a million more questions that I didn't ask that I'd be interested in. Hopefully, to anyone listening and watching, I know we have a lot of med students, physicians, a lot of employed physicians who are watching this who may one day think about starting a private practice. Where can they find you?
Just find me on X, and you can DM me on X. I don't have a website anymore, or I'm not on LinkedIn or anything like that. Just find me on X, DM me. I'd love to talk to you.
Awesome. All right. Thanks so much. And we'll see you hopefully soon.
See you soon.